So now we come to the last talk on the OCT and glaucoma.
So, ma'am has beautifully elaborated the role of OCT in neuro-ophthalmology, and she highlighted the importance of RNFL and GCL. I will go little basic in this because those are the last point to consider. Before reaching at those points, we have to see certain things in the OCT print. I will go on to that. So, first, the glaucoma, we all know it is a multifactorial progressive degenerative optic neuropathy, and it is second most common cause of blindness. And OCT is a non-invasive tool to in vivo cross-section the optic nerve and retina. Historically, first machine was HRT, which used to measure the optic disc. Then comes the polarimeter, which interpolated the thickness of RNFL. It was not actually measured the thickness. OCT is the first machine which actually measuring the structure, and there is no interpolation. So OCT can measure the nerve fiber layer. It can see the optic nerve head measurements, and it can see the macular thickness. What is the importance of these three in glaucoma? As you can see in this picture, the ganglion cells, their axons, they exit out from the optic disc. So we are measuring the optic disc parameter. Around the optic disc, we are measuring the RNFL, which is basically the axons of ganglion cell. And in the GCL, we are measuring this ganglion cell and inner plexiform layer. So this is essentially a single structure which we are measuring at different areas. So as ma'am highlighted, there are different machines, and different machines have different algorithms. Like for RNFL thickness, they are taking different diameter circles. So we cannot compare one machine with another machine. So you should always do OCT on a single machine. Similarly, for the optic nerve parameters, the reference is different for different machines. So scans obtained with different instrument will differ in data, and you cannot compare on two machines. OCT is objective in nature, whereas visual field is psychophysical. So we have, I will be talking about Cirrus HD because we are using this, and I have no financial interest. So I have divided the whole printout into 7 parts. So we usually directly come to the part number 6 and 7, but before that there are 5 parts which we should consider before going to the 6 and 7. The first one is patient information. In this, we have to see the registration number, because if you will do on with a new registration number every time, the machine will take it as it is a new case, and it will not compare with the previous data. Age and sex is important because it is for the normative data. The machine compares your reading with the normative data, so age and sex is important. Second is signal strength. A poor quality scan will lead to a lot of problems in the segmentation. So in this, in our machine, it is out of 10, and you should get at least 7. This is NFL thickness map. It is basically topographic representation of the thickness. In a normal patient, it should look like this in hourglass pattern of red and yellow, and the values are given here. Color coding is given according to the thickness, and this is normal. For thinning, it will look like this. So, and what happened here, if you look at this, there is a black area. It is black because there is a floater in the vitreous which prevented the acquisition of data. So in such case, you will ask patient to look briefly to one side and then again fixate, so that opacity is on the side and you can actually capture whole of the data. If you will proceed directly to the 6th part, it is red, and you will say it is thinning, but actually the problem is data is not captured here. Similarly, if patient blink during the scanning, you will get this black line. So for this, you will ask patient to keep blinking physiologically when you are adjusting the machine, and just before starting taking the scan, you will ask him to stop blinking. The next thing you have to, at number 4, you have to seek the RNFL deviation map. In the deviation map, there is red and yellow dots. They are showing red one is thinnest normative data ka thinnest 1%, and yellow is thinnest 1 to 5%. So this is showing comparison with the normative data. another important thing which we have to see here is placement of the circle at the optic disc. So this centration is important. If it is more than 0.3, your data will go haywire and you should not proceed. You should do the scan again, and this centration should, like in this case, it is decentered. It's 0.33. So it is not acceptable. You have to center it in less than 0.3. So in this example, as you can see, there are deviations. It happened because of eye movement during the scanning. Usually we ask patient to look at a fixation which is green in color and the scanning lines are red in color. So when patient is looking at the green circle, suddenly when red lines start coming, he suddenly moves his eye toward the scanning laser, and it lead to this kind of artifact. So you will ask patient specifically to keep looking at the green line spot and stop looking at the scanning lines. So you have to correct. If it is there, you can see at the sixth part it is coming yellow. Again, this is not reliable. Similarly, if I have done this, there's a the patient, I have done this and I have manually decentered this, and you can see it is totally normal in this case, but it become yellow in this case because of decentration. And it is the same patient 5 minutes apart. Similarly, when I corrected it, the values are corrected. The fifth one is RNFL and optic nerve at segmentation. So you can click on the computer and you can see the 360-degree that segmentation is correct or not. In optic nerve head, there are two lines, one is black, one is red. So black ends at basement, then RP opening, that is BMO opening. You should see that in poor scans, it may move from its normal place and lead to the erroneous values. And the red one is the least distance from this, and in certain conditions in poor scans it may not be at the right place, so you have to manually check this before proceeding ahead. And similarly for the RNFL, there is segmentation here, so you have to check whether the segmentation is proper or not. Now we have reached the value which we see at the number 1. So here we can see the green color is there, gray color is there. The green color is when your data is between 5 to 95% of normative data, it will become green. When it is thinnest 1 to 5, it is yellow. If it is less than 1, it is less than 1%, it is red. If it is thicker than 95%, it is white. Then what is gray? Gray is it is outside normative data. Here the disk size is more than 2.5. If it is more than 2.5 or less than 1.3, the data will be in gray. Or if your patient age is less than 18, then also it will become gray in color. So in this we see the average RNFL symmetry. For the disc we see the rim area, average CD ratio and cup volume. But you should know the color coding. And similarly RNFL, this is shown in the graphical manner. The continuous line is for the right eye, hashed line is for the left eye, upper one is for neuroretinal rim and lower one is for the RNFL. And RNFL is also shown in quadrant and clock hour. So what is the importance of showing in the clock hour and quadrant? The importance is initially the glaucoma loss is in sectoral. It is in a specific clock hour. So for example, in this case, you can see it is red here, yellow here and white here. White means it is thick, it is borderline, it is thin. But when you will see the quadrantic map, it is flattened. It has become green. So it will give you the assumption that it is normal. But you should always look at the clock hour and correlate it with your visual field and clinical photograph. The GCL importance in neuro-ophthal was highlighted by ma'am. Now it has importance in glaucoma also. So because essentially the RNFL and optic nerve findings are related with ganglion cell, it is the extension of axons are extension of ganglion cell only. So we have to check these also. It is measured by a macular cube of 6 by 6 and it is measured in a saucer shape. Basically it is not measured in the central area. It is done because central area there is foveal curvature, and in the curvature it is very difficult to measure. The ganglion cell layer is not there, it is very difficult to measure. So it is measured in a donut shape. The inner diameter is 1 millimeter and outer is 4 millimeter. and the values of GCL IPL thickness is shown as average as well as minimum. And the earliest changes in glaucoma is seen in inferotemporal quadrant. So you should always look at that quadrant, correlate with your glaucoma findings. There is one more software, glaucoma progression analysis. In this, when you are repeatedly doing OCT for a same patient, two baseline OCT, good quality OCT are taken at baseline, and they are compared with the future OCTs, and in these different values are compared, and they will give you possible loss, likely loss. If it is one event, it is possible, it is coming again, then it become likely. But like in this example, in certain part it shows that the patient is progressing, but on the next visit it become normal. It happens because there is 4 micrometer standard deviation in the machine. If you are taking values again and again for the same patient, there is 4 micrometer deviation. So for 2 standard deviation, there should be at least 8 micrometer deviation to be significant. Though the thing which I was highlighting, PanoMap has also come, in which they are comparing RNFL, optic nerve, GCL and macular thickness in the same printout. And there is combined report in which they are, with the software you can compare it with the visual field also. What is red disease? This normative data is for the normal persons, not for the atypical eyes or high myopic eyes, because those eyes have thin macula and their optic nerve head findings will not match with the normal patient. So when you will do OCT on a myopic patient for glaucoma, you will get thinning, and they are actually, when you will do the field, they are absolute normal, they remain there, and the GCL also thin, but because they are coming red because they are overall thinned out compared to the normal population. So you should not treat myopic patient on the basis of RNF, on the basis of OCT only. So at conclusion, I would like to say you have to look at the entire readout. Don't directly jump at the RNFL values. Maintain a good quality reading by monitoring the scan signal quality, alignment, centration, and watch out for the opacity and segmentation error. Look for focal changes, not just overall change. 3 most common RNFL progression patterns are new RNFL defect, widening of existing defect. If there is deepening, the deepening can occur because of aging effect. Because with age per year for the RNFL around 0.3 micrometer, the progression loss will be there each year. Use trend based, basically you have to follow a patient on a same machine and see the trend of RNFL. Don't compare one event with the whole of the baseline findings. And again highlighting the same point, important and mandatory is the same machine, same place, reproducible image quality to ensure meaningful evaluation and follow-up. And last, there's one thing, floor effect. When there is advanced loss, the finding will reach in 50s, 45 to 50, and it will not decrease further even with the progression. And at that stage, you will not use OCT for evaluation. You will use 10-2 a visual field for the in monitoring. The OCT is of no use in advanced disease. Thank you.
Thank you, Anil. As we have come to the last talk, if you have any questions, I think we'll be very happy to discuss with you.
So one point I want to highlight for the glaucoma is that a single OCT may not be predictive of glaucoma. You have to have serial. Number two, how do you correlate the disc, the fields, and the OCT? So you must have a disc photograph next to it. So do not, without a disc photograph or disc, analyze the glaucoma. Take a red-free photo, that will give you a better clue. Number three, the ganglion cell only gives you the central 10 to 15 degrees. So the Heidelberg OCT gives you a 24 point. So your fields may not match to the ganglion cell, but if you see the thickness of the whole retina and with the macular thickness map, it may match to the field in the beginning. So you may have no field effect in the central 10 degrees, but you may still have glaucoma, and vice versa. You may have ganglion cell, but may not have a field effect. So either can be exclusive, and you have to be careful. Follow-up in glaucoma, the follow-up is most important, and we tend not to take a disc photograph. The disc photograph, I think, is more important than the OCT or the field, because that gives you a lot of clues. And the RNFL defect should match the disc photograph. If it is an error, it doesn't match, take a OCT again, because in a OCT, sometimes because of cataract or the quality of the image is poor. Okay, thank you. Pardon?
OCT, how it helps in myopia?
In?
Myopia.
So in myopia, the OCT doesn't it just for the glaucoma or for the other part.
Glaucoma.
So glaucoma is a problem because until you have a swept source, you will have aberration. You have to put in the refractive error, and in myopia there is peripapillary atrophy. So OCT is not as accurate in glaucoma as in others. So the problem is that OCT only works in a clear media. OCT doesn't help in a prior PRP eye or operated vitrectomy eye or a myopia eye, because in all those cases you will have an error of, and especially in peripapillary atrophy when you're doing a RNFL, that's why you tend to see the ganglion cell layer if you think that the peripapillary atrophy is there. So that is the limitation of OCT. Floaters, media haze is a limitation. So we depend too much. Yes, you can say there is no glaucoma when you have a glaucoma suspect, but you can miss a glaucoma on the OCT in the beginning. So I think serial disc photograph, serial RNFL, defects on a red-free photo, the OCT, all add up to this thing. So I'll say if you do gonioscopy, use the central lens to see the disc. That will give you a lot of clue of things more than the fields and the other things.